So this topic is about chronic obstructive lung diseases, which is one of your final. Let's begin. We start with the basic definition of COPD. What is COPD or RCOPD? Those are diseases which are characterized by airway obstruction, which is not fully reversible by bronchodilator. So like a sort of like a permanent airway obstruction. And it is due to inflammation of the small airways in the lungs. What do you mean by obstructive? Obstructive means that you are referring to the expiration of the air. So the air is obstructed from leaving the lung. And thus the alveoli are left hyperinflated because the air does not leave the alveoli, it does not get expired, so the alveoli remain hyperinflated, which is not a good situation. So what diseases come under chronic obstructive pulmonary diseases? COPD, the diseases are chronic bronchitis and chronic alveolar emphysema. You need to be specific: chronic alveolar emphysema and chronic bronchitis, not bronchiolitis. This is a mistake here. Chronic bronchial obstruction is not fully reversible, as we spoke. Risk factors are smoking, number one, as for any other lung disease. Smoking, dusty environment, alpha antitrypsin deficiency. These are the most common risk factors for COPD. Macroscopically, you expect to see parenchymal hyperinflation, as I mentioned, and emphysema, vesicular tubulus. And clinically, you will expect chronically productive cough, called blue bloaters in some literature, and dyspnea. Why blue bloaters? Because of cyanosis, they will be blue and they will be coughing. So blue bloaters. Complications would be very important to remember complications. So you will, since you are not able to expire the air from your alveoli, you will suffer with hypoxemia and hypercapnia, which will further result in vascular vasoconstriction of the lungs, resulting in pulmonary hypertension, and finally chronically cor pulmonale, which is right-sided heart failure. Okay, and very important to know is that you need to state COPD into 4 stages, which is called the gold criteria. And it's very important because the treatment depends on this gold criteria. Basically, these stage, for example, if it is stage 1, 2, 3, 4, that determines what kind of treatment, pharmaceutical treatment the patient needs in the moment. So you need to mention that the stages 1 to 4, according to the gold criteria, are important to know for COPD. Your examiner will be waiting for this statement. Okay, well, what further information your examiner will be waiting for is that there's a decrease in FEV1 and decrease in the ratio of FEV1 by FVC because it is an obstructive disease. I'm sure from pathophysiology and physiology you can make sense out of this statement, hopefully. Yeah. Okay, so this slide just pictorially represents let's explain chronic bronchitis. What is chronic bronchitis? So a healthy bronchiole will look like this, and an unhealthy one due to chronic bronchitis will look like this, due to inflammation, excess mucus, and muscle constriction. So there's a smaller lumen. That's why there's like chronic productive cough and dyspnea. And as well as there's alveolar emphysema. So this is the healthy alveoli, and this is the alveoli with the damaged membrane due to alveolar emphysema. And all of these result in wheezing, weight loss, chronic dyspnea, cough and sputum, and chest tightness. Why weight loss? Because the person is spending a lot of energy in breathing. It is not a passive process anymore, but an active one. Okay, so now we go into specifics of what is chronic bronchitis and chronic alveolar emphysema. First, let's begin with chronic bronchitis. We divide bronchitis usually into acute and chronic, and we do not care about acute here, just mentioned here for your reference. We care more about chronic here because we are talking about COPD. These slides, by the way, are from Professor Bilbui's presentation, which I found really good for this question specifically because it mentions the question precisely according to the information needed in your final exam. Um, so credits to him for these slides. Okay, so chronic bronchitis. Definition of chronic bronchitis, clinically defined as a productive cough for 3 continuous two years, together with emphysema as part of COPD, for example, and often in old long-term smokers. Pathogenesis, you could take a read here. Smoking results in mucus hypersecretion, inflammation, mucosal atrophy, hypertrophy, further resulting in number of submucosal glands increase compared to the bronchiolar wall width. This results in the read index, right index. I don't know how to pronounce it. Yeah, right index for the read index being increased. The normal is the normal read index is 0.4. And if you have more glands than your bronchiolar width, then you are susceptible to infections and exacerbation. Wait, let me show you a picture of how to calculate read index. Yeah. So here we have a picture of read index. Uh, yeah. Here we have picture read index. What is it exactly? So here we have the tall columnar ciliated pseudostratified epithelium, the respiratory epithelium. And then we have the submucosal glands behind it, and then finally the cartilage as the outermost layer of the bronchus. And when you have chronic bronchitis, your submucosal glands layer increases in size tremendously. That the ratio of AB upon CD sort of increases a lot, and we do not like the situation because we don't want so many of these glands, and that's when we say that see the read index increases and the situation is bad, so it makes it susceptible to infection and exacerbation. What is the morphology? Goblet cell hyperplasia, more mucus production, chronic inflammation, so lymphocytic infiltration, bronchial wall fibrosis because of chronic inflammation. This is the microscopic morphology. Clinical signs are chronic cough, hypercapnia, hypoxemia, cyanosis, like I explained. Complications, emphysema, infection, chronic core pulmonale, like explained, and then death. Okay, additional points for chronic bronchitis to be remembered. Smoking also leads to, in addition to what we already spoke about, smoking also leads to ciliary dysfunction, hence resulting in buildup of mucus. This all leads to air trapping, the distal mucus plug, and hypoxemia because the air cannot reach the alveoli anymore. Morphology, gross morphology would be air trapping and inflated parenchyma. This we already saw. Okay, emphysema. So emphysema here, what exactly is emphysema? Is increased airiness of the lung parenchyma. This will be also described in a separate question. But here we talk about emphysema with regards to COPD, and there are two, mainly alveolar and interstitial. In this question, we will focus only on alveolar because the alveolar emphysema happens in COPD and not the interstitial one. So I will only speak about the alveolar emphysema. Alveolar emphysema very prominent in the name that it is about the alveoli. affecting the alveoli. We speak about acute or chronic alveolar emphysema, and we only speak about chronic alveolar emphysema because this is the one which happens in COPD and not the acute one. There are different reasons for the acute alveolar emphysema, which we do not need to talk about at the moment. You can take a read later when in your free time. So, what is chronic alveolar emphysema? It is permanent inflation, hyperinflation of the air plus destruction of the alveolar septa. Most common etiology is COPD, like mentioned, and you classify it according to morphology. It is not clinically significant, but it's good for with regards to your exam preparation and for your exam studied. We go from most common to least common types of chronic alveolar emphysema. The most common is central SNR, caused by pneumoconiosis and smoking. Then pen SNR, mainly congenital alpha antitrypsin deficiency. Then distal and SNR, spontaneous pneumothorax, and then irregular and bullous. Not very common. Most common, like the first three are the most important ones to know. Complications of alveolar emphysema were very important: decreased expiratory volume, decreased gas exchange, hypoxemia, hypercapnia, vasoconstriction of blood vessels, pulmonary hypertension, cor pulmonale chronicum, chronic right sided heart failure. You need to know this whole series step by step, series of complications. Okay. This is just a pictorial representation of the types of chronic alveolar emphysema. Most common one, the central lobular one, will look something like this. The pan SNR will look something like this. This will be like this, and irregular like this. Don't focus much on this. I just put it here. If you want to spend time on this in your free time, you can. Um, and this is a lung with how with emphysema, and this is how it will look like. Uh, when you compare it with the healthy lung, you will know the difference that it doesn't look good morphologically. And that's about it for this question. I covered the most important info which you will need for your exam, so hopefully you should be good. All the best.